Be with you in about 2 minutes, everyone. Sit tight.
Hello. Hello.
She said to hold on a minute. She's waiting for other people.
Hi, everyone. Sorry, we had some technical difficulties. Okay, so if everyone could just put yourselves on mute.
What did I do?
I'll do it for you, Miss Evans. Okay, so let's get started. Everyone can see my screen? Thumbs up? Yes? Okay, perfect. Okay, so good afternoon and welcome everyone. Again, if you're just joining us today, welcome. Thanks for taking the time to join us today. For those of you that do not know me, my name is Sheila Redding. I am the APDA's Information and Referral Center Coordinator here at Rutgers Robert Wood Johnson Medical School. I'm pleased to welcome you to our annual Living Well with Parkinson's Disease, a conference designed to people with Parkinson's and their families. I'd like to take a moment just to thank Amneal Pharmaceuticals, Medtronic, and Kiwan Kernan for funding this important conference and acknowledge their appreciation for the critical need to provide these educational programs for people with impacted from Parkinson's. So today's speaker is Dr. Yeva Fernandez. Dr. Fernandez received her medical degree from Ross University and completed her neurology residency here at Rutgers Robert Johnson Medical School, where she was chief resident. She then went on, oops, sorry everyone. She then went to Mount Sinai in New York, where she completed her movement disorder fellowship. She has an expert training in deep brain stimulation and ultrasound guided Botox injections. In 2018, she joined the faculty of Rutgers, New Jersey Medical School in Newark. And in March 2020, she joined us here at RWJMS in New Brunswick. So I'm going to now hand it over to Dr. Fernandez, and she will proceed with the presentation.
Yeah, I guess it's the same on the last. That's what we can do on the report. Well, we did it with the report. Yeah. Because you just pre-ordered it in sometime in December, we then didn't go in the mouth under our name. So it's good. Yeah.
I'm not hearing anything.
Can hear you.
Oh, okay, hang on one second.
I see. Can you hear me now?
Yes.
Oh,
Yes.
I'm sorry about that. Okay. And everybody can see my screen?
Just says Yeva Fernandez.
No, I
Yes.
can't see the screen.
No, I
You can't see my screen. All right, let's see. My apologies. Let me try one more time. Okay, I'm gonna get back onto this, share screen. Okay, and allow. Can everybody see now and hear me now?
Yes.
Wonderful. Sorry about that. So again, hi everybody. Thank you for joining us, and I'm very sorry about the technical issues. My name is Yeva Fernandez, and I'm here to talk to you about DBS and other surgical options, but most importantly, making an educated decision regarding these options and understanding what the process is. If you have any questions, please, you're welcome to type them into the chat box. We'll be taking note of them, and we'll answer them as we go along or at the end. So starting off, so the question is always, why do deep brain stimulation? The question, when people are, for Parkinson's in particular, deep brain stimulation is particularly effective for tremors. So when you are taking medications and they're not controlled by tremors, or you have a side effect of medications such as dyskinesias, which are these rolling, sometimes wriggling movements, which could be really uncomfortable, embarrassing, or
I can't see you.
you can't see me.
No.
You can't see me. Okay.
Don't worry about seeing her. It's just if you can see her screen.
Okay. So this is when dyskinesias, which are these rolling or wriggly movements, are not controlled by medications, or when someone has dyskinesias on very low doses of medications such as cinnamon or carbidopa levodopa. Why else do deep brain stimulation? We do them for motor fluctuations. So this happens when people are taking medications and they suddenly drop off on the effects of medication and need to take increasing doses, or the medication's not lasting for consistent periods of time. Another reason why to do deep brain stimulation is for slowing, which is the fancy word for that is bradykinesia. If you have stiffness and rigidity, or you have involuntary muscle contractions, which are called dystonia. So some people with medications are just the effect of Parkinson's, or they have a genetic condition of dystonia, which basically causes them to have involuntary muscle contractions, curling of their toes, twisting of their neck or torso, or when they just have intolerable side effects of medication. But at the end of the day, what this boils down to is having a better quality of life. Okay, so if you haven't seen a DBS before, this is a diagram courtesy of Medtronic, where you can see that there's a small battery placed in the chest wall area, and they're connected to wires which are placed in the brain in specific targeted areas, and they deliver impulses, electrical impulses to disrupt abnormal signals in the brain. Okay, so what does deep brain stimulation do? What is this for? Deep brain stimulation is most effective for tremors, dyskinesias, and dystonia. This is exactly what it was designed to do. And there are several targets that we use for Parkinson's and essential tremors. I'm going to just briefly mention these targets, including the the subthalamic nucleus in the thalamus and the GPI in the globus pallidus for Parkinson's disease, as these are the known areas to be affected in Parkinson's disease. And also the ventral intermediate thalamus and the central zona incerta in essential tremors. Again, another thalamic target. The STN for us is a more popular target, and in general, compared to the GPI, due to the preference of the surgeon, the GPI does tend to be a much smaller target, and it has a little less risk, and we have to balance the risk and benefits of surgery, basically deciding what target is best for the patient based on their symptomology and also on their anatomy. But we also have to consider what are side effects from the stimulation. So just to briefly review this with you, one of the things we look at for the STN is that if the patient needs help with controlling dyskinesias or tremors, an STN target would be excellent. It allows for medication reduction, but sometimes it can be associated with behavioral disturbances. Whereas the GPI, although a smaller target, it does help to control a person's dyskinesias, dystonias, and tremors. But generally, we maintain the medication doses with a lesser side effect. Now, deep brain stimulation has been around for at least the last 30 years. However, the mechanism of action is not clearly defined. There are lots of proposed theories and lots of studies going on to define this mechanism. However, no singular mechanism has been clarified. However, it is agreed upon by the DBS community that it works for the right candidate. And what we know is that what we are doing is delivering electrical impulses that disrupt abnormal signals that are occurring in the brain to cause U-negative symptoms for Parkinson's and for your essential tremors. Excuse me. We have to weigh the risks and benefits of DBS. Now, often we think DBS, are there such things as risks and benefits? And with any surgery, there are risks. And one of the risks is there's a 1 in 100 peri-procedural stroke and hemorrhagic risk. So there's a 1 in 100 chance that you can have a stroke during the procedure or bleed. That also depends on the surgeon that you're working with. Infection, as with any type of procedure infection. Sometimes you can have a worsening of gait, worsening of speech, and again, as I had mentioned before, some behavioral disturbances.
This is you. I know.
Okay. So often when people are making this decision for DBS, we find that there's an expectation of what exactly does the DBS help? And it's easy to say that it helps with everything, but I would like to kind of review what does, in studies, what exactly does it not help with specifically? It was not designed to do. It does not necessarily help with gait. It does not necessarily help with gait freezing. So that occurs when you're trying to get up or you're in a narrow space and your foot gets stuck to the floor. It doesn't necessarily help with balance. And it doesn't exactly help with axial tremors, rigidity, or postural, meaning tremors that occur in the trunk or what we call camptocormia, or a very stooped, a profoundly stooped and bent over posture. It does not help with swallowing issues, and it does not help with the voice. So hypophonia, that low, hoarse, scraggly voice. It does not help with someone's cognition, and it does not help with symptoms of dysautonomia, which is your body's normal regulatory mechanism of keeping blood pressure up and managing blood pressure, constipation. It's the normal metabolic functions and the homeostatic functions to keep the body moving from day to day. Okay. So I would, when we're talking about DBS, we have to clearly state that what does DBS not do? And then we'll review what it does do. DBS is not a cure for Parkinson's. It is not something that we know at this time that modifies the disease. In other words, it does not change progression to our knowledge at this time. We have no definitive studies that show that. So therefore, it's definitely not a cure. It does not guarantee that you will be totally off of all of your medications for Parkinson's disease or essential tremors. But if that happens, and that's wonderful, but have we ever seen that happen? Yes, we have seen that happen, where people have had really wonderful results and significant reduction off of their medications, or to very, very low doses of their medications. DBS does not bring you back to your physical status before Parkinson's disease came about. So in other words, it does not bring us back to when we were 20 or before you even had the disease. DBS does not guarantee a complete elimination of your Parkinson's symptoms. Its goal is to reduce them. So some people, they say, I'm going to get the DBS and and it's going to get rid of my tremor 100%. I cannot guarantee that to anybody, but it does reduce them significantly, and it's a process to get there. So, but it's understanding that we try to make your symptoms much more tolerable, or reduce them to the point where you have a significant improvement in your functioning. But as I said before, there's no definitive evidence for disease modification, which is basically the slowing of the course of the disease, because as we know, Parkinson's in general, or essential tremor, are slow progressing diseases.
Can you tell how long DBS lasts on a patient?
When you say how long does DBS last on a patient, what do you mean? Like can I see it in the beginning?
If they have reductions in symptoms, does that last for the lifetime, or it's a period of time and they need to maybe get another session of DBS? Does that make sense?
I'm going to touch on that in a few minutes if you're willing to wait a little bit. And if I haven't answered that question, I'm going to definitely answer it at the end. I promise. Okay?
Sure.
Okay. So I already told you what DBS cannot do, but let's focus on the positive, which means what DBS can do. And the goal is to maintain you at your best response that you have on levodopa. Okay, so it can reduce tremor significantly. It does improve slowing. It does improve stiffness or rigidity. And it does improve overall mobility for our patients. And it does reduce dyskinesias, which are the extra side effects from medications, the wiggling motions or the writhing motions that you can get from levodopa. And it can potentially reduce the amount of medication you are taking, which basically means it's reducing the negative side effects, which include hallucinations, which include dyskinesias, and which include blood pressure. But we're doing this as a consequence of reducing medications, not directly through the DBS. Okay. DBS, DBS helps to manage side effects of your Parkinson's disease medications, which is what we had talked about, but I may not have to add on extra medications to manage side effects. Sometimes if you are familiar with having dyskinesias, you are taking another medication such as amantadine to try to help mitigate that mitigate those dyskinesias. If you're having side effects of hallucinations from your levodopa, then that might mean you might be taking something to help manage those hallucinations. And what we're trying to do is to try to mitigate your medications and not have you take all these other extra pills. Okay. So realistically, if you ask me what is DBS, DBS is another treatment tool that we have in our box to help you. It provides us with more options to customize your treatment. It gives us the ability to create programs through the deep brain stimulator specifically for your individual needs. So sometimes when you're getting a DBS, if you say, hey, doc, I want to walk, but sometimes the programming, it makes it very hard for me to do this and do that. We can set you up with programs that help you walk. There are some programs that are helping you with your tremor and your dexterity and your slowness, and you are able to flip through those programs as you need for what is suitable for you at that time. And again, what it can do is improve your quality of life, which is the goal of managing Parkinson's. So when I speak to my patients and they say to me, I'm interested in DBS, how do I know I'm a candidate? How do you decide? It's not exactly how I decide. It's what we decide as a team, as a patient and doctor team. And we look at things such as your age. Age plays a big factor because it also takes into consideration someone's cognitive and behavioral status. It also takes into account your overall health. We also look at the stage of disease that you are in. With Parkinson's, if you are in a early to moderate stage of disease, you may really benefit from the DBS. However, if you're in very late stages of disease where you're not walking or you're really debilitated, it may not be a good option because it does not take into account, it does not change the course of the disease, and it may not restore the functions that you have already lost. We also look at other medical comorbidities, like, are you on blood thinners? Do you have any other issues that would require you to get repeated MRIs, back issues, pain issues, blood pressure issues, diabetes? Because all of these things affect your ability to heal. All of these things affect your ability to do well. And we also have to look at what treatments have you previously had for Parkinson's disease or essential tremor. Now, we also have to take into account your responsiveness to medications, particularly levodopa. As I said briefly before, DBS tries to keep you at your best response on levodopa. It is not a replacement for levodopa. So we try to keep you at your best response to levodopa. We also look at support systems. This is a huge commitment. And we want to make sure that you have a support system such as family or someone who's available to help you during this time, because it is a long process, not necessarily entirely arduous, but it is a process that you're going to need help with, including healing or, just somebody to be there for you. And most importantly, we look at what your expectations are. If you're going to say to me, I think, this is going to be the cure, this is the great panacea, then we have to have a talk about what are we looking to do? How are you looking for the DBS to help you? So you want DBS. So now what? How do we move forward with this? How do you even start the process of getting evaluated? So if you're following with us at Robert Wood, you're probably already seeing one of us, myself, Dr. Paul, Dr. Chen, or one of the other neurologists. So the first step is we evaluate you, and for someone who has not seen us, they're establishing care with a movement disorder neurologist or one of our neurologists. We have to take a look and first agree that you have a condition that is compatible with the use of deep brain stimulation, such as Parkinson's disease or essential tremor. We have to establish where you are in your stage of disease and what medications you are taking, okay? And then our neurosurgeon has to see you to assess you for your surgical candidacy. And we also have a neurosurgery. We work very close with our neurosurgeon here at Robert Wood. So that's actually a wonderful thing. And we go through something called a dopamine challenge. So I don't know if anybody's ever heard of this dopamine challenge. Sometimes in the literature, you'll hear it called a CAPSIT. And what that means is we're going to have you come in and be a couple of hours off of your medication entirely. So we want you to have a washout of all your levodopa to see what you look like physically and how you are operating without any medication in you. And then while you are here, we will start giving you your levodopa and then monitoring how your body responds to it. And then we grade you according to the UPDRS, and we see how much benefit you are getting from that levodopa. And then we have to do something called a neuropsychiatric evaluation. And this is actually very important. And what this evaluation does is that it is done with our neuropsychologist, who gives you a series of tests that basically assesses you for any type of memory or cognitive issues, and any deficits in memory or cognitive issues. It can also help with detecting any type of depression or any other psychiatric comorbidities that may play a role in your ability to deal with having the DBS, work the DBS, and explain what you are feeling while you have the DBS and your ability to operate the DBS once you get it. And after we have that, we start planning for surgery. And what that means is we talk about this. We talk about all the things that I just discussed, the evaluation, the dopamine challenge, what the surgeon thinks. And we take a team approach, a multidisciplinary approach to say, would this person really, really benefit from DBS? What are they going to get out of it? And then we plan for surgery. And that means choosing a target. And then discussing with you, bringing you back and discussing with you how you would like to proceed and what are the expectations, and then what is to come moving forward should you choose to proceed with the surgery. And then once you have the surgery, it depends if you're getting one side or both sides, and whatever other surgical comorbidities that can be occurring, you have to recover from the surgery. So we test the battery during the surgery, but we do not turn it on. We do not turn on the machine right after, because you need to heal. The brain, when you're doing this surgery, we are creating a small lesion in that area, and that area needs to heal. So some people say, hey, I feel really good after the surgery. Did you turn the machine on? And I say, no, we didn't turn the machine on. It's just your brain is in the process of healing. So we're waiting for you to heal. So then we are able to start your first programming session, which is the most exciting part. Okay. So, you know what? I'm going to go back to your first programming session. So during that first programming session, what do we do during that time? We actually have to do a couple of things. And it's a checklist of things that we do first to make sure that your battery is working well. And then we check the contacts on the leads to make sure, one, that they're working, and also to find an ideal contact for you. Then we slowly program you to see how you are doing on these settings, and we send you home, and we keep in contact with you and might bring you back in for a second programming, just to see how you're feeling and how you are doing on your session, on your current settings. Okay. So it's a commitment. It's a big, big commitment. DBS is a long-term commitment for the patients, their neurologist, and a neurosurgeon. We're practically all married to each other when this happens, which is a good thing. Okay, everybody's in it for the long haul because we are committed to getting you to be at your optimal motoric state. That means we are committed, everyone is in to get you to be working at your best place. We want you to feel well, we want you to function well, and we want you to be able to have a better quality of life. And again, this is a commitment. So that means your DBS is going to be a work in progress. When I say that, what does that mean? You've already gone through all of this and you had the surgery. So are we there yet? No, we're not there yet. We're going to get there though. And that means multiple programming sessions. It will take some time to find an ideal setup for you, meaning that you're going to have to come back to your doctor's office to make adjustments to the DBS settings as often as you need. Some work right away, and you know, some people say, I got it, it feels good, I'm good. But some people say, you know what, I'd like to tweak it a little bit more because I'm noticing this symptom is going away, but I want to try to get a little better. Or you're having some side effects that are undesirable from your current settings, and we have to go back and reevaluate them. Okay. As I said before, DBS does not change the course of the disease. The disease eventually does progress, and we have to make adjustments to the DBS settings to basically account for these progressions. And that is going to be limited by any side effects from the programming. And it's going to also be limited by how much you're tolerating the programming sessions. It takes, you know, it can be an exhausting process, but also very fulfilling. We want you to have optimal results, but it takes a little bit of time and patience. Sometimes people do weekly and monthly follow-up visits in the beginning, and as they become more stable, we stretch that out to monthly and sometimes even a yearly follow-up when the programming is stable. But DBS is also requiring some maintenance. Battery changes when needed, and these battery changes will depend on the system that you are using and the amount of energy usage that your DBS consumes. So there have actually been a lot of the companies out there now are trying to put out longer lasting batteries, rechargeable batteries, and part of picking out a unit for you will be talking with you during the evaluation to see what your preference is and what would be suitable for someone based on their age or their ability to, do surgeries down the road. With DBS, there's going to be some restrictions, okay? There's going to be some limitations on some of the things you do in your daily activities. So roller coaster rides or any activities that cause jerky movements of the head, probably not recommended. Definitely no contact sports or activities. So roller derby and boxing are out. No MMA for anybody. But when you travel, you'll have to take precautions when you're passing through surveillance, including the X-ray machines. And we give you guys cards from the manufacturers to let you know what when you're traveling, to let you know that you have to show it to the airport, so the airport personnel, so that they are aware that you have a unit that has some restrictions, and you will have to have a different type of surveillance. Okay. Now, MRIs in the future, some people ask me, can I get an MRI? Yes, you can, but they are done with some restrictions and some planning. We have to find out where the MRI is going to be done. What is it being done for? If your unit is compatible with the MRI machine and the MRI setup. And also, basically, how often will you need to get MRIs? Now, part of this is also understanding physical limits. You still have to take the same precautions that you did when you were before the DBS. So I don't recommend scuba diving below 40 feet or 30 feet, because that's just a no-no with DBS. But I also say if your balance wasn't that great before, I would not recommend, even with DBS, that you try to climb a ladder if you were not able to do that prior to that. Okay. So sometimes people say to me, I want to see what this is about, and I want to try getting DBS. How do I choose a center? And that's a good question. You want to go to someone who has experience. You want to see what the references are, and we're going to talk about that. So there are lots of options, okay? In the tri-state area, you have multiple hospitals, but are those hospitals or hospital centers geared towards movement disorders? Are they movement disorder centers? You could see a private neurologist or a hospital, like private neurologist, and they might have privileges at a hospital. Here at Robert Wood, we are a movement disorder center, so we have a division that is focused solely on movement, and this is our expertise. And then you have neurologists in academic centers who are general neurologists who may work with a DBS, and they can try to do some of the evaluations. So that's one option. Okay. You also want to look at the neurosurgeons. You have to ask them, how many have you done? Is this your specialty? Are you a back surgeon who does this, or are you somebody who really does neuromodulation and has done multiple of these surgeries and has good experience, has good training in this? Okay. Sometimes I also say, asking the surgeon, how many DBS surgeries have they done in the last year? It's easy for someone to say, hey, yeah, I've done this before. But if they've done it before 5 years ago, that might be a different issue, as opposed to, yeah, I do these routinely, and I might do at least 20 or 30 of these in a year. Okay. It's also important to ask your surgeon, what are your rate of complications? What are the complications that you have? What are the potential complications that I could have? And then, so you've gone do all of this, and you're saying, so who decides if I'm a good candidate? And as I said before, here we work as a team. So we work in a multidisciplinary approach where we have a neuropsychiatrist, your movement disorder specialist, your neurosurgeon, and our nurse practitioners, and our neurophysiologist who join us in these discussions. And we all give our input and also provide advice from our perspectives of how you would benefit as a candidate. After you go through the surgery, like I said, it's going to be a process to adjust the programmer. So you might want to find out who is going to be managing my programming after surgery. Not all neurosurgeons manage their programming. They have neurologists who work with them, or neurophysiologists who work with them to manage their programming. You want to know what is their expertise and experience. So, somebody who's done DBS once in a while here and there and does very basic programming, or someone who does DBS and has a lot of experience. They do, they see patients for this almost every day, and they know how to really manipulate the programs and, set up individualized, customized programs for you. Is there a team working for me? In other words, as I said, is there a multidisciplinary team working for me? Are there going to be a lot of people there to address the multiple issues that are going on at once? You also want to look at the reputation of this, where you're having your surgery done. Accessibility. Accessibility is quite important, because sometimes you're going to need to come in often, and you might not want to be traveling very, very far. But if traveling very far is not a big deal for you, then that's okay too. But it's something for you to consider. And as with any job, references and experience. Can I speak to somebody who went through the same process? Ideally, you might want to speak with somebody who's already had the surgery from the same surgeon and is working with the same team that you may be working with. Okay, so I've touched a lot on DBS, but I also want to kind of discuss with you perhaps other surgical options for the management of tremors. Now, there have been many surgical options through the years. And I've already covered DBS, which has been around for the last 30 years. And we discussed that maybe one or more electrodes are inserted into the brain and connected to an impulse generator that provides electrical stimulation to modulate or interfere with abnormal signals reaching a certain target in the brain. The effects are delayed and can be varied based on programming, which is what we have been talking about. It's a work in progress. And this has been available for the last 30 years. But what most people don't know is that it's not entirely a new concept, because prior to that, there was something called a thalamotomy. And that was done using radio frequency. So a probe was inserted into the brain, and that was used to create a strategic burn or lesion in a selected area of the brain. And sometimes the effects can be immediate, and that's been around for the last 50 years. And then there's also something called a gamma knife, where we're using ionized radiation, basically without having to go through the skull to create a lesion. Yes? Okay. And the effects of that may take anywhere up to a year. And that's been available to us basically because of technology for the last 20 years. And finally, I'm going to touch on this concept of focused ultrasound, or MRI guided focused ultrasound. Now, this is the new kid on the block, and this is the new kid that's being advertised to a lot of people. And it sounds really nice because it is basically surgery without having surgery, or so they say. But again, this is about making an educated decision and keeping you informed. And what this technique is using ultrasound waves that are transmitted through the skull. So there's technically no cutting. And that is also creating a permanent lesion in a targeted area in the brain. And the effects are reported to be immediate. And this has been roughly around for the last 8 years. And if you look at all of these things that I've mentioned, DBS, thalamotomy, gamma knife, they have, and focused ultrasound, all of these things have one thing in common. And these things have basically focused lesioning of targets in the brain. The only difference is DBS is the one where we are providing constant stimulation. The others are not getting constant stimulation. You're just creating a very, if I were to put it basically, you're creating a very small focused hole. Okay. So I'm going to focus a little bit more on the MRI guided focused ultrasound, because like I said, it's the new kid on the block. We're often asked about this because it's an incisionless surgery. It doesn't need to be performed with anesthesia, and we don't use radiation. Some people do not like the idea of having radiation near them. This was approved as of July in 2016 for refractory unilateral, meaning one-sided essential tremors. It has been documented to be used for Parkinson's disease tremor and some Parkinson's symptoms. This is an option for patients who refuse or are not good candidates for other procedures such as deep brain stimulation. It is considered safe. However, like with any other treatment, there is a risk of side effects. The particular side effects in this case would be gait disturbance and paresthesias about 1 year after surgery. And paresthesias is that funny feeling, that numbness, but not really, kind of odd feeling, kind of is as if you were hit your funny bone. But that can be quite annoying for people. There's also been some reports of some mild weakness in an affected limb. And it's, excuse me. Okay. We can only do it on one side. We don't do it on both sides because we do not want to cause you any other issues. especially in a movement disorder. So it's ideal for only managing one-sided symptoms. So if you say, you know, I'm a right-handed person and my tremor is just so awful on the right hand, and I can't get DBS because I have this health issue, I'm prone to bleeding, I cannot get off of my blood thinners, or, you know, I'm elderly and I really can't stand to go through a very rigorous procedure, then this might be an option. Okay, and this is just a quick picture. So I want to point out that this is actually what we see on an MRI afterwards, where they did this thalamotomy, focus ultrasound lesioning right here. So this is the lesion that they created, and it was targeted and placed in a very specific spot to help with a specific symptom. And then 6 months down the road, we do another MRI to see, and you could still see that that's a lesion there. Okay. Whereas if you do basically, if you do a CAT scan or if you have a DBS, you can see that bright shiny object, which is basically the contact, the metal contact on your MRI lead. Okay. So do they both create lesions? Yes, but the DBS has an added effect of basically we're programming, whereas you cannot do the programming with a lesion, with the other techniques. Okay, so are there problems with focused ultrasound? Yes, and some of these problems can be variable. Often people ask me, if I do this procedure, is it going to be forever? Am I going to have a good effect forever? And in one study, no. Some people had a return of tremor after the first year, and that may be due to the brain healing, scar tissue forming, or progression of their disease. So it's not a complete guarantee. Some people, after doing the lesioning or surgery with the focused ultrasound, that they have swelling of the tissue in that brain because we're creating a strategic injury, but sometimes that lesion can spread unintentionally. And it has been seen and documented. Again, it's not suitable for both sides of the brain. It's not possible in people who cannot do MRIs because you need an MRI to guide the process. Sometimes if you have a really thick skull or bone density in the skull, the targeting becomes very difficult because they need to get through, and they need the ultrasound to get through without bending or targeting unintentional areas. And if you've already had a previous brain surgery, it is not recommended. And because it's a newer procedure, there's not that many people who have the experience to do it. Also, a lot of people say, hey, they're not cutting into me. This is great. I'm not having surgery. But at the end of the day, we're creating a focused lesion. We're creating a strategic lesion. So even though somebody's not cutting into you, they are still creating a hole, which is a surgical process. There are also some unresolved issues and things that we need to look at down the road, which means what are the long-term side effects? Can we reoperate in the same area? How long does this last? Is it safe to do it later on down the road, maybe to do it on both sides? Are there going to be better MRI targeting? What is the bleeding risk, especially in patients who are on blood thinners? And is there such thing as a placebo effect, which has been documented? So I think I'm going to get back. Can everybody see me? I'm going to stop sharing my screen. And if you have any questions, I'm happy to answer them.
Okay, thank you, Dr. Fernandez. I'm going to share my screen, and we do have some questions, so you'll be able to see the questions, and we'll go through them like that.
Okay. So somebody asked before, does DBS not help? DBS does not help with balance. Are there specific treatments that do help with balance? So DBS, some people do report like, hey, I do walk a little better with DBS. And, I might stand a little straighter. I might be a little stiff. I might be a little less stiff. So that that may indirectly help with their balance. But what really I think helps people with balance is gait and balance training, physical therapy, and exercise. Because the reason why I say that is I think it's strengthening, getting your body to understand and build a memory of how to move in space, especially when you're not as well balanced. And it also teaches you techniques to stand up straighter, be more aware of what you're doing while you're walking, swinging your arms, because all of these things, although we take it for granted because we don't sit there and think about it, that those things are important to be more aware of, because you're gonna have to think about it. And those type of gait and balance training programs, physical therapy, exercising, dancing, these are all things I think do help with balance. But DBS can, I think, also have an indirect effect of helping with balance. Okay. Excuse me. I don't want to sneeze in front of everybody. Okay. Is DBS usually covered by insurance? Yes. We still have to go through an approval process, but yes, DBS is usually covered by insurance. But that would also depend on your insurance, your individual insurance company. Okay. I had a very successful DBS, let me see, 11 months ago, with tremendous improvement in tremors and almost elimination of my freezing of gait, and even uptick in both energy and executive function. On the negative side, I have experienced a deterioration in voice and vision. Is there a workaround that my MDS programmer, my movement disorder programmer can use to offset these two issues? Okay, so actually I want to say congratulations on your DBS and improvement in the tremor and freezing of gait. The freezing of gait is actually a really wonderful thing when I hear something like that, because one, it's a pain, and two, it's a safety hazard if you do have a freezing of gait. So I'm glad that you were able to have benefit to that. However, you did experience some like side effects. So one of the things that we work around is programming. There are programming techniques. We would have to evaluate your programming because we want to make sure that it's not, your voice is actually not being affected by your current programming and giving you a negative side effect of affecting your voice. However, there is also a workaround where you can have a separate setting for walking and tremor, and a separate setting, a customized setting, where you are not, having to be walking around, and it would affect your voice less. There are other workarounds where you have the option to adjust your programmer so that you are able to improve your quality of voice and speaking when this happens. So there are plenty of options, and I think that nothing is ruled out yet, but it does take a little bit of time to get there. Okay. How many DBS has been performed in Rutgers Center during 2018 and 2019?
So I actually asked Eric.
Okay.
And as of right now, he wasn't, off the top of his head, wasn't sure about the numbers for 2018, 2019. But as of right now, from July 2020 to right now, 2021, we're up to 25 cases.
That's wonderful. That's actually a very good number. In the last year, things have probably taken a little bit of a slowdown because of COVID, but yes, it is. We are a robust system. We are a robust DBS programming and DBS center. So that is actually a very good number. Can someone taking Dilantin for epilepsy be a candidate for DBS? Well, I don't think that Dilantin itself is going to be the issue for DBS. We would have to coordinate care with your neurologist who is helping to manage epilepsy to see if you would be a good candidate for DBS, because actually, believe it or not, DBS or these stimulators have also been used for the treatment of epilepsy. So we don't want to trigger any issues with epilepsy. However, the ability to do this is it is possible, but it would take a little bit of coordination of care and to understand where the seizures are coming from. If it's lesional or something that's a genetic type of epilepsy or some sort of primary type of epilepsy. So it's not ruled out. Dilantin would not be the bigger issue. In other words, medication would not be the bigger issue. And it has been done before. Okay. In MRI ultrasound technique, where do you create the lesion? Do you burn the Lewy bodies? Okay, that's actually a really, really good question. Okay, so in MRI ultrasound technique, the lesions, again, this was specifically designed for management of tremors. Mostly it's used in the case of essential tremors, but the lesions are generally created in the thalamic regions of the brain, contralateral to the side of your tremor, meaning it's in the thalamus on the opposite side of which hand is affected. Do I burn the Lewy bodies? So Lewy bodies, that's a very good question. Lewy bodies are actually aggregates of protein that we see pathologically on a pathologic slice of tissue. In Parkinson's, we do see Lewy bodies, not in person because we would actually need a piece of tissue, and we don't go in and get a piece of tissue. That means it's pathologic. So we'll see this pretty much after someone passes away. But is there potential to burn Lewy bodies? Yes, but Lewy bodies can be located anywhere in the brain. It's very hard for us to say exactly where they are. So is there a possibility we might burn a Lewy body or a group of Lewy bodies there? Yes, but we don't specifically target them. Okay. Okay. Does focused ultrasound help with rigidity dominant Parkinson's? Also a good question. There have been cases where people have reported that they have had an improvement in their Parkinson's with focused ultrasound, and that includes the slowing and stiffness, which we call bradykinesia, and increased tone or rigidity. But we're not sure. The study was not sure, and very specifically said it was not sure if this was due to a placebo effect. The goal was really to help with the tremor. So I can't say for sure that the focused ultrasound does help with rigidity. We don't have, most people, I would say if we were to talk about that, I would say DBS would help with more rigidity than focused ultrasound because we have more evidence for that. But we don't have a lot of evidence for that for ultrasound. Okay. How many years of experience do I have with programming? I've been doing this since I was a fellow, so it's been a couple of years, probably 5 or 6 years. Okay. Does DBS produce dopamine? Now that's a good question. And that's something that people are looking into. So when we talk about Parkinson's disease, it's as if I always say to my patients, Parkinson's disease boils down to one thing, dopamine, dopamine, and the dopamine we do not have. So as I said before, we don't have specific evidence that DBS is disease modifying. So I do not have any specific evidence that it produces more dopamine, because dopamine gets progressively lost, or the cells actually that produce dopamine they progressively deteriorate as the disease progresses. So as of this time, I cannot say that DBS produces dopamine. Okay. How about its ability to help resume normal bladder control? Now, that's actually also an interesting question. Bladder issues, or the need to frequently go to the bathroom, especially at night, is a persistent issue that bothers people terribly, terribly with Parkinson's disease. I have not had people report to me that it helps to resume normal bladder control. There are several factors taking into account for this. The reason why I say this is DBS generally occurs in people 50 and above. While it does happen in younger people, the trend is generally 55 and above. For men, there is the extra complication of developing prostate issues, which happens to the majority of men in general, that the prostate enlarges and they just have to go to the bathroom based on the mechanical issues associated with that. And that means, does the DBS fix that? No. Does the DBS fix the urge for you to constantly go to the bathroom? No, not really. But it may make it easier for you to get there at night or during the day. What I normally do is refer people to a urologist, because there are medications that can reduce the urinary frequency, or I introduce behavioral modification for this, meaning we don't drink water like 2 or 3 hours before bed, unless it's to take a sip of medication or to wet our mouth. And we drink strategically if we have to go around during the day, especially if urination is an issue during the day. What type of behavioral changes can happen with DBS? So that's a good question also. Sometimes people can become compulsive. Sometimes people can be very anxious, and it's not necessarily just due to the DBS. Again, it's not only DBS's fault, but you're putting, with DBS, there are wires that, based on the target, that go near circuits of the brain, and that are responsible for some of our emotional and cognitive responses. And it also depends on your programming. So we really have to watch out for these things. Sometimes depression, sometimes euphoria. I've seen people where they're like, this is great, this is fabulous. And then other people say, oh, you know, they feel really low. So we monitor that with our programming, and modify our programming based on those responses if they occur. Okay. Do you have experience with the Boston Scientific? I personally do not have experience with the Boston Scientific, and that is because it was out on the market several years ago through studies. And more recently, Boston Scientific is now starting to hit the market. So it's also a function of when it actually hits the market and its availability to us. So we've been dealing with the other two competing companies, but I have been to trainings with Boston Scientific, and they do join us if we need their help. Okay, does DBS fix crawling of your toes? Okay, so that's actually a good question. It can, if the toe crawling is due to dyskinesias or dystonias, yes, it can. We just basically have to do the programming to see how we can help you with that. But yes, we have used it to help with the toe. Oh, okay. And I've had DBS done for 5 years at Rutgers. I have been going back every 3 months to see Debbie about tune-ups. Lately, within the last 2 weeks, it appears to have stopped working. Any ideas? I will be at Rutgers on Monday at 2 p.m. Well, okay. So there's a couple of things we have to take into consideration, okay? You've had DBS for the last 5 years, and I had mentioned before that, while we have the DBS, we're trying to control your symptoms, and that is, that's something that, we try to do with the DBS in conjunction with your medication, but sometimes there is a disease progression, and we basically have to program in that setting with that consideration. Now, if something changes like abruptly, where in the last few weeks things are kind of getting a little cloudy and they may feel like they stopped working, we take into account several things. One, we want to make sure you're not, there's nothing else going on in the background, such as like a cold or infection, or some sort of abrupt health change. And then other things are, we have to reevaluate your programming, see where you were, and basically do small adjustments to see how we can try to get you to your previous, where you were happy on your programming without causing you side effects. I'll probably be around Monday, so I'll be happy to stop in and talk with Debbie about that and talk with you. So we can try to do that. All right. And then, hi again. The bladder question I asked about before is actually the opposite. Oh, in my case, I have a problem emptying the bladder. Okay, again, so now this kind of begs the question, for males, some people have difficulty emptying the bladder for men because basically when you're peeing, you're basically urinating through a pinched straw, and that can be problematic because you're basically increasing the resistance of where the fluid is trying to get out. So you might have to go several times because you can't completely empty a bladder if this is for a male. And the reason why I say that is, sometimes they give you, the urologist can give you something to kind of relax or shrink the prostate, or what they can do is sometimes basically give you medications to relax the bladder from activating and pushing against a very hard resistance. If you are female, there's lots of things to consider in this case. One is to make sure that you don't have anything obstructing, such as stones or any scar tissue there. But also, we want to make sure that your bladder is not underactive, and that you have good, good strength. Sometimes for women, even though, if you've gone through childbirth, then that can also give you long-term effects of emptying your bladder because, well, just the mechanics of childbirth and being pregnant can affect that. But it can also be, just the general function of your bladder. But DBS, I would not say for sure that DBS would really improve that function. Okay, and I think there was another question that popped up, but I'm not sure.
There's one more question. If you are not yet on levodopa, are you a candidate for DBS?
Ah, good question. Some people will say yes, but my question is then, if DBS is supposed to keep you at your best at levodopa, then how would we know that you were doing well on levodopa to begin with? So I would say I would recommend someone try oral medications before trying a surgical option, because you don't want to go through the surgery and realize you were not the right candidate for it.
Okay, I think that is about it for this afternoon. Dr. Fernandez, thank you so much for that very informative talk. Now, if anybody does have any additional questions, please feel free to send them my way and I will relay them to Dr. Fernandez. Otherwise if everyone, I will see you all tomorrow if you are joining us for tomorrow with Barbara Kelly for a exercise session. And that's about it. Dr. Fernandez, thank you very much again, and see everyone tomorrow.
Thank you very
Thank
much,
you.
everybody, for joining us.
Bye.
Thank
Thank
you.
you.
Bye.
Thank you very much.
Thank you.
Thank you greatly.
Oh, thank you. Hello.
Familiar,
Okay.
huh?
Yes, yes. Everybody, thank you so much for joining us. I greatly appreciate your time. And if you have any questions, please don't hesitate to ask us. Thank you. Have a good day.
You
You
too.
too.
Bye-bye.